My name is Glenn Pierce. I'm the Vice President for Medical for the World Federation of Hemophilia. And welcome to the second in the series of webinars from the WFH on practical guides for managing bleeding disorders. It's our pleasure to welcome a series of speakers today, and I will introduce those in a few moments. And we're going to have over the next 2 hours a interview-style discussion on gene therapy for hemophilia, some of the latest results, a presentation on liver health and hemophilia, and then we'll move into a session on von Willebrand disease, and not only data from the ISTH meeting, but also why it's important to our community. And then we'll finish with prophylaxis using limited resources, what some of the achievements and the expectations have been. So with that, I would like to introduce some of our speakers today. I'd like to introduce Steve Pipe, who is Professor of Pediatrics and Pathology at the University of Michigan. He is also the chair of the Medical and Scientific Advisory Council for the National Hemophilia Foundation, and has been very active nationally and internationally as a clinical scientist, researcher in the areas of new products, including quite a bit of work in gene therapy. So he'll be leading off our discussion today. I'd also like to introduce at this time Heiner Wiedemeyer, who's a professor and head and chair of the Department of Gastroenterology, Hepatology, and Endocrinology at Hanover Medical School in Germany. Heiner has been involved in a number of clinical trials for liver, antiviral trials, immunotherapies, for viral hepatitis, and has been very active on the research side as well as on the clinical side in understanding damage to the liver. And so we'll look forward to his presentation. And then I will also introduce Nathan Connell, and he is going to be speaking on VWD. He's an assistant professor of medicine at the Harvard Medical School and associate physician in hematology at the Brigham and Women's Hospital in Boston, Massachusetts. And he's been very interested in thrombosis and hemostasis with some focus on von Willebrand factor as well. He's been involved in the guidelines panel as well for the new guidelines that we have on von Willebrand's disease. And then our second speaker on VWD is Dawn Rodolini, who has been a leader in the bleeding disorders community for many years. She's the parent of a son with hemophilia and founded the Rocky Mountain Hemophilia and Bleeding Disorders Association in Montana, where she served as the executive director. She was executive director there for a number of years, and then for the Western Pennsylvania chapter in Pittsburgh. And she's been with the National Hemophilia Foundation for over 12 years as the chief operating officer. She's also on the board of directors for the WFH and has been actively involved there. And then the last person I'll introduce is the person who will moderate the last section, which is Cedric Hermans. And Cedric has been very active in hemophilia over many, many years. He's the editor-in-chief of the journal Hemophilia. He's on the board of the WFH, and he heads the division of hematology, hemostasis and thrombosis unit in St. Luc University Hospital in Brussels, Belgium. So he'll be managing the last part of the conference. So with that, I would like to begin. I mentioned Steve, and so we'll start. Steve, you're on board here. I can see you. And so we're going to try something a little bit different this morning. Consider it an experiment, which is always a good thing to do. And we're going to get into a discussion about gene therapy and some of the latest results. And this is really very timely because we just finished the International Society Thrombosis Hemostasis, ISTH meetings this past week, where quite a bit of clinical data were presented for gene therapy trials, both phase 1/2 as well as phase 3. So let's get into a discussion about that. And one area to start is something that you and I have been talking about now for quite a while, questions about the outcomes in gene therapy clinical trials, focusing specifically on the variability between patients who receive the gene therapy. So how much factor do they have on board after receiving it? The durability of the expression, how long does it last? Does it work? Does it prevent bleeds? And the safety implications of gene therapy, both in the short term and the longer term, since this is a therapy that is with one for a very long period of time. So based on some of the data that have come out of the ISTH, would you like to comment on variability first, and then we'll cover some durability?
Sure. And maybe just to update people, what did we actually see at this conference? So we saw results from both factor VIII Hem A programs and factor IX Hem B programs. We saw results from phase 1/2. We saw results from some updates on phase 3 trials. And I think there have been several themes that we can take from that. From a variability perspective, it seems pretty clear that the variability, particularly in the factor VIII programs, remains quite wide. I think easily a 10-fold range or more in expression, even for patients who have received the same vector doses of AAV gene transfer. For factor IX, I would say the variability also remains pretty significant. What I think we're getting some clarity on, though, is that over time, some of that variability seems to be narrowing. So if we look in the early sort of 6 months to a year after gene transfer, that's where we seem to see the widest variability. And then over subsequent years, there seems to be maybe a narrowing of that variability into a range. From a overall expression perspective, I think what we're seeing is a little more consistently getting results that are in the near normal to normal range from the factor IX programs. For the factor VIII programs over time, I think we're seeing patients who are, at least after multiple years of follow-up, the majority of the individuals are in the mild range. Some have even dropped off the lower bounds of the curve and have now had expression levels that are below the level of quantitation. From a comparison between the 8 and 9, I would say my assessment of the results from the Hem B programs is that the expression seems to be pretty consistent over the long term. We had updates from AMT-060, which was the precursor vector with wild type factor IX in Hem B patients. And this was an AAV5 vector. Those patients now have been followed for 5 years. And even though the expression level overall was in the lower range, the highest dose cohort sort of in the 5 to 11% range, factor IX expression, that has been pretty consistent now over 5 years. We have data on the 1-year 52-week expression from the phase 3 study from AMT-061, which is the same vector, but with the highly active Padua variant. So of course the expression is a multiple higher, 5 to 8-fold from the wild type. But these patients now through week 52, it's a large cohort, 54 patients that were dosed in that phase 3 trial. And the mean factor IX activity is just over 40%. And if we look at the population of patients from about 6 months through now into a year, really no evidence of some trailing off of the activity levels. I think you and I have shared continued concerns about what we're seeing from the Heme programs. So we saw at this meeting 2 longer-term follow-ups from phase 1/2 programs, BMN 270, as well as the SPK 8011 trial, both Heme programs, different vectors, BMN 270 being AAV5, SPK 8011 being a derivative, if you like, of an AAV8 vector. And we had 4 and 5 year updates from that phase 1/2 program with BMN 270, and a 3-year update from the SPK 8011 program. My assessment of the data that's been shown is that there is some drop in activity over time. I think the majority of the patients still seem to be sustained within the mild range. However, if you continue to look at the tracking from year 1 to year 2 to year 3 and so on, there does seem to be a steady decline over time. We can make some suggestions that maybe the slope of the decline may be changing over time, but I've seen no observations from the trial data that's been shown so far that we have what I would call stabilized that expression. And so this is a curious observation why we're seeing this difference for the factor VIII programs.
All right. Well, thanks, Steve. You've really covered the gamut here from these clinical trials. So let's get into a couple of specifics. Here's a tough question for you. Do we have any clues on how to predict which patients will do well on gene therapy and which won't? You described all of the variability that we see, a 10-fold variability from low to high. How can we predict, given the same dose of vector and what appears to be a similar kind of a patient, who's going to respond and who's not?
This is a relatively homogeneous group with regards to eligibility. We're looking at men 18 and up, severe, maybe to moderate severe. Some trials have accepted up to 2% expression levels. Liver health had to be, pretty standard assessment based on, no advanced fibrosis. They could have hepatitis history, but they had to have gone through, sustained viral response to anti-hepatitis C therapy, but not homogeneous with respect to their clinical presentations. Lots of variability in patients who were they on prophylaxis before they came into the trial? How much joint disease did they have before they were transduced, et cetera? So when we look at the outcomes, yes, from I would say a transduction of the liver, this group looks pretty similar, but from the response to that gene transduction, how much expression they have, and then what's the impact on their bleeding, I think we are seeing some heterogeneous responses. My guess is that if we were able to get liver biopsies in all these patients, we would probably see at comparable doses that the amount of transduction at the liver cells is probably pretty similar. But then you have a host of all other factors that are contributing to how much expression is actually coming out of those cells. How much protein are they able to produce? It could even go back to, how well did these transgenes form into their episomal structures inside the cell? How well do they access the machinery so that the genes get turned on properly, that the message levels get transcribed, that the protein level gets secreted efficiently through the cell? So you start adding up all these variables, and we start to see we don't have any predictors for these. The predictors that we think about outcomes are all those clinical things that we can examine in a patient. But these are all cellular and genetic mechanisms inside a person's body that is just a black box to us. And so I would say, no, we have no prediction on who's going to get that 5% level or who's going to get that 150% level from the exact same gene transfer strategy.
Well stated. And, that's been a frustration of mine as well, because that black box, there just hasn't been a lot of effort in the entire research community to figure out what's inside of it. And yet, if we did understand what was inside of it, for instance, if we examined liver biopsies and understood what was happening in the cell to the transgene, to the expression of the transgene, that offers the opportunity to look for drugs to intervene, to boost expression. And some of those drugs exist and have been done in animal studies, but nothing really has made its way into clinical translation, which could provide for more homogeneity in the response.
Now, one thing I would say is that I do think we're getting clarity on the correlation between expression levels and bleed protection. I think the trials are actually backing up a lot of the hypotheses that people had going into these trials. What kind of thresholds were we going to have to meet in order to abrogate bleeding?
Yeah.
And it seems pretty clear now that if you get even into the high, moderate, or low, mild range, you can suppress the vast majority of spontaneous bleeding, particularly joint bleeding. But we also know this from the way we manage patients outside of gene therapy. If you have substantial joint disease, you probably require even higher levels to completely abrogate breakthrough bleeding. And so I know people have looked at these trials and they said, well, we see patients with expression in the 25% range, 30%, and they're still reporting, sporadic bleeding. Well, I think that's our experience with adult patients as well who have advanced joint disease. So I don't think we should be surprised at that. I'm encouraged that we hopefully have convinced people that the outcome measure of the factor level is probably a very good, at least co-primary outcome for these studies to verify what the degree of protection is likely to be.
Yeah, I think that's a good point, and especially about the patients who have joint damage, pre-existing joint damage. They sometimes do require higher amounts of factor. So to summarize this part, it's worth emphasizing that despite all of the variability, patients are winding up in the low mild to higher mild range and have substantial protection from bleeding, regardless of the variability. How long that lasts, we're not sure for factor 8. For factor 9, it looks like it's going to last for some substantial period of time. In our last couple of minutes, I do want to cover safety. And maybe you could very briefly address the concerns about short-term safety and the use of immunosuppressants to manage the short to intermediate response, and then long-term safety.
Sure. Well, I think across all the trials, it's now very clear that the primary treatment-related adverse effect is elevation in liver enzymes as a marker of some form of liver toxicity from receiving these vectors. I don't believe we have the whole story about what the mechanisms are that are involved in that transaminitis. If you look at the phase 1-2 trials, almost all of those treatment-related adverse events occur within the first year. We now have up to 5 years of follow-up. If there are any late elevations in those liver enzymes, it looks like they're not leading to the need for additional management. So those early treatment-related adverse events of elevated transaminases, those all are receiving corticosteroids as per protocol. And the majority of the participants are able to see resolution of those transaminase levels, some inconsistency on whether there's any impact on the expression levels of the factor, whether it's factor 8 or factor 9. But for the majority of individuals, they'll go on steroids for a period of time. They'll eventually be able to wean off, whether that's within the first 6 months or certainly within the first year. And then after that, we're not seeing really any evidence of ongoing treatment-related adverse events related to that. So in the short term, that's what we should be still focusing on. We've certainly seen some infusion reactions in the first 24, 48 hours. This is pretty typical for any biologic agent infused, and those have all been very manageable. Long-term side effects, as you and I have talked before, as many others have, there's this concern about what's the impact potentially of integration events. The AAV platform was brought first to the clinic because we expected the vast majority of the transgene elements were going to remain episomal in these circularized episomes outside of the chromosomes of the cell. But we have some biopsy data now, which has confirmed that at a rate of, probably, 1 to 2 per 10,000 cells, there is a degree of integration events where portions of the transgene end up integrated into the DNA in that cell. So what this has raised is whether these, if you want to call them rare integration events, could trigger some sort of a cancerous transformation of cells. So in the liver, of course, this would be hepatocellular carcinoma. Well, this population already carries unique risks for this cancer already. Hepatocellular carcinoma is strongly linked with prior infection with Hep B and C, 80% of all cases. And the gene therapy trials have not excluded patients with a history of Hep B and C. They do have to go through some treatment to eradicate the Hep C virus. We have excluded patients with advanced fibrosis. They seem to be the highest risk for hepatocellular carcinoma development. And that's where the liver screening comes in. But we have all accepted now that the hepatocellular carcinoma risk is reduced, but not completely eliminated with Hep C eradication. So what transpired in one of the trials, the HOPE-B gene therapy trial, is that there was a single participant who 1 year after gene transfer had a per protocol liver ultrasound and was demonstrated to have a liver mass, and a biopsy determined that this was hepatocellular carcinoma. This was not present before entering the trial. He was 69 years old. He had a history of Hep B and C, contracted more than 30 years ago, of course. He had gone through eradication, but he did meet eligibility for the trial. At the time of surgical resection to downstage him, a second lesion was identified. This was treated with chemoembolization. That participant's going on for discussions regarding liver transplant, but what we had opportunity is he had sampling at the time of surgery of both the tumor specimen and the adjacent normal tissue. And this was subjected to extensive genomic analysis. And that's where we were able to show that consistent with prior AAV gene therapy, integration events were very low. Turned out it was at a rate of 0.027% of the liver cells. And notably, there was no dominant integration site within the hepatocellular carcinoma sample. Rather, what we saw were multiple structural chromosomal variants, large chromosomal rearrangements, mutations, and oncogenes, all of which have been well described to occur in hepatocellular carcinoma independent of gene therapy. So this provided solid evidence that at least the hepatocellular carcinoma developed in this patient was unlikely to be related to gene therapy treatment and really attributable to the patient's underlying risk factors. But this does highlight for me sort of the challenges of gene therapy. Almost certainly this will not be the only case of a malignancy that happens to occur in a patient who's gone through gene transfer. And as long as we continue to enroll patients who have histories of hepatitis B and C, there may be other events, maybe over multiple years, where we might see some additional hepatocellular carcinomas. I think the first few events that come up probably will be subjected to this kind of genomic analysis. But if the results keep coming back, no dominant integration site, no evidence of activation of oncogenes, characteristics that are typical for those cancers when they occur in the absence of gene therapy, I think this will continue to bring reassurance that this platform of therapy, AAV gene transfer, is not triggering malignancies over the long term.
Okay, thank you, Steve. We're going to need to move on, but we will get into a Q&A session after Heiner's talk. So I would encourage you, all of you in the audience, to use the Q&A box and raise questions. Put questions into the Q&A box, and we will see what we can cover following Heiner's talk. So I've already introduced Heiner. Heiner, welcome, and we'll look forward to your talk. Ready to go.
Thank you very much, Glenn, for involving me. So I have really to disclose I'm a hepatologist. I have treated myself many patients with hemophilia for hepatitis C virus infection with my colleagues here at Hanover Medical School. But for me, it was very interesting to follow your field over the recent years, because it's obviously very interesting to really to bring gene therapy to life. And I have to also to state that for hepatologists, we are looking now even closer to your field, as we are only in the very early steps to really explore gene therapy for other diseases in hemophilia, for example, Crigler-Najjar syndrome, where we have the first data, which is now also entering our field. And therefore, all the issues that have just been discussed by Steve and Glenn regarding variability, safety, how to understand why some patients express the gene of interest, why others either on a lower level or whether there are changes over time, they are extremely relevant for our field. I wanted to briefly discuss with you my ideas on liver health and hemophilia, and some of the issues I want to discuss have been touched in the previous discussion, which was really very interesting. Can you give me the control? Yeah, here we are. Okay. So these are my potential conflicts of interest. This does include companies who are also exploring, let's say, strategies for gene therapies in the field of your diseases. Very brief remarks on very basic aspects of the liver. The liver is a unique organ. It's very special. It's has different cell types, and all of these cell types we may consider when we talk about efficacy, safety, what is happening to the liver, etc. Obviously, we're talking about liver cells, hepatocytes. These are the cells that you are targeting with gene therapeutic approaches, but we have other cells also, and some of these cells express your factors of interest. So we have stellate cells, we have endothelial cells, we have cholangiocytes, we have different immune cells in the liver, and then you have to understand also that the liver is unique, as we, for example, have cells inducing tolerance. So after liver transplantation, when you transplant an organ full of foreign antigens to a patient, we are able to wean these immunosuppressive agents in a substantial proportion of patients completely. So I'm following at Hanover Medical School. We are the largest liver transplant center in Germany. I just saw this morning a patient, 25 years after liver transplantation, who does not take any immunosuppressive compounds, which I think is really unique to the liver. But the same question as Steve and Glenn just discussed, we have no good tools really to predict which patients may make it without immunosuppression. And then when I look to the liver, actually, what are we looking for as an hepatologist? Obviously, liver enzymes, but we have also differentiate hepatitis from cholestasis, which is also in terms of toxicity to me completely different. I look at what is the liver doing, what is the liver producing. The liver is also clearing substances. And then obviously we're talking about fibrosis and liver cancer. We have different tools which we can investigate, and then we have different patterns when we determine toxicity. And this is for me really important, because a hepatitis pattern is for me a completely different approach I will target as I would talk about the cholestatic pattern. And then obviously we are an aging population. Fat is really something which is also important, because we have a variety of new compounds which may also target fibrosis progression and also steatosis. As a hepatologist, I have my lab values, but I really rely on a good ultrasound. And in Germany, we as hepatologists are performing the ultrasound ourselves, which I think is really useful. You understand a lot about blood flow. You're not only looking for images in terms of liver mass, yes or no, but we're looking to blood flow. We are looking on the bile ducts and so on. We have obviously liver elastography, which is very well established, and then we have a variety of non-invasive fibrosis markers. In your context, when you talk about gene therapeutic approaches, and it has just been discussed the issue of short-term toxicity, long-term toxicity, but I'm also interested in comorbidities, because these comorbidities may really have a role to let's say, evaluate acute and long-term toxicity, because we discussed not only the post-hepatitis C issue in terms of cancer risk, but for example, when we talk about steatosis, if a patient develops acute hepatitis by different mechanisms, then obviously It's important to understand whether I talk about an overweight patient with diabetes who is 70 or a younger person who is lean, no diabetes, etc. So what I do as a hepatologist, when I see elevated liver enzymes, I talk about a bystander hepatitis, which is very frequent and it's underestimated. So for example, this morning I saw a patient with autoimmune hepatitis, and she had suddenly elevated liver enzymes, and we were not clear what was the cause. She received her second dose of COVID-19 or SARS-CoV-2 vaccination 3 weeks ago. And she had 3 weeks later an increase in liver enzymes, which I consider as a bystander effect after vaccination. We'll come back to this in a minute. I obviously investigate autoimmune liver diseases. We have hepatotropic infections, and we have drug-induced toxicity, which is very frequent, also difficult to protect. But my task in the clinic is that we have really frequently not only one cause and of these elevated liver enzymes, and it's really challenging to dissect the different causes of hepatitis in this context. Bystander, I just mentioned. So if, for example, you have a flu infection or develop SARS-CoV-2 or whatever, you expand T cells targeting a bug. And then they proliferate, and then maybe in some instances you have 5 to 10, 15% of your CD8 positive T cells targeting an infectious agent. The question is, what is happening to these cells? They go to the liver, they die in the liver, and then they may trigger apoptosis there. They may trigger other events, and this bystander hepatitis after expansion of T cells is much more frequent than we thought. And if you would regularly follow many patients, you will detect elevations of liver enzymes. Obviously, we have hepatotropic infections. We talked about hepatitis B and C. But in your case, you also should look to the most frequent cause of acute viral hepatitis worldwide and also in North America and Europe, and that is hepatitis E virus infection. It's emerging. So in Germany, for example, we have 400,000 hepatitis E virus infection every single year. And the source is a zoonotic infection. It's in the meat. Pigs carry hepatitis E. It's much more frequent than we thought, so it's something you should not forget in the differential diagnosis of acute hepatitis. Autoimmune liver diseases, it's a big topic, underestimated, and we may also, with virus infections, viral vector, trigger autoimmune events. We have here clear diagnostic criteria in the hepatology field. But there, I think you need a hepatologist to really judge, is this hepatitis, autoimmune hepatitis, or something else? And then we talk about drug-induced toxicity, which may again overlap to autoimmunity. Also here we have clear guidelines. This is, for example, our European guidelines, how we address this. It's different mechanisms. HLA types may matter here, but again, it's a whole spectrum of toxicities which needs to be considered in this differential diagnosis. In your case, and I will skip these slides briefly, you talked about this vector-associated short-term hepatitis, which is responsive to steroids, as Steve just explained. In almost all cases, also in the patients where we have been asked as a consultant how to deal with these vector-associated hepatitis cases, it's manageable. And I'm not really that afraid of a fulminant hepatitis in early after gene therapy. In my view, in most cases, this is really manageable. My concern is if these low levels persist, is this one factor about AAV-associated immune responses that they limit the efficacy of these gene therapeutic approaches. Again, this has been touched. I will skip these slides here. And overall, also the frequency of elevated enzymes in the long term is very low. Again, Steve mentioned this, that if these hepatitis cases occur, it's usually after a few weeks or months. And later on, as here shown in this study in dogs, that late liver enzyme elevations is very rare. Long-term safety, this has also been touched, and we may discuss this. I will not comment anymore on the risk of clonal expansion in your field. Probably this paper has been discussed frequently. These clonal expansion of transfused liver cells here in dogs in the long term. Yes, this may happen, and again, the risk has been nicely discussed by Steve, that this is probably a very rare event, but I think something simply that has to be followed. I think it should not be preventing us from applying these treatment approaches, but we have to follow carefully. And I saw one question in the chat, whether what's about children. Yes, we have to be even more careful, but in my view, I consider this also as a very unlikely event, that this integration is the cause of cancer development. It may happen, but we have to see. To me, again, and I touched on this, the most important point is comorbidities. I'm really more concerned about comorbidities and the risk for, let's say, loss of efficacy of gene therapeutic approaches or cancer developments. And obviously, we're talking here about post-hepatitis C. I will come back to this in the end in 1 minute. But again, the metabolic issue is really something we are following in our field very heavily. You know that there are at least 50 to 100 compounds in clinical development targeting metabolic associated fatty liver disease. So either directly interfering with the fat metabolism, or with fibrosis progression, or with inflammation. So this is an exciting field for us, and which may then also be relevant for you, the liver health in hemophilia patients. My last brief words are really regarding hepatitis C. And if you remember, one message from my talk is then, if a patient is cured from hepatitis C, game is not over. This is my point. And you talked about that with HCV treatment, you reduce the risk to develop HCC, but you do not eliminate risk for HCC. This is data from our center. We have a lot of follow-up studies now. There is, even in an HCV cured patient, a remaining risk to develop liver cancer. And this is something for us that therefore we need surveillance even after HCV cure. Just to rush with some data, which I just presented at the European Liver Congress 3 weeks ago. It's the German Hepatitis C registry. We are following close to 17,000 patients with hepatitis C. And the message is here, HCC risk still remains, let's say, an annual risk of 0.5 to 0.9% per year. And then we show these Kaplan-Meier curves. Obviously, in patients starting off with cirrhosis, there's a substantial risk over time to develop an event. But even in patients with no cirrhosis, some patients in the long term may develop events. They still have sometimes elevated liver enzymes. And this is what we have to keep in mind. And therefore, my last point is, why is this the case? What is happening? And let me just use the term, and I don't want to I will skip these slides, and that is what I call long hep C. Long hep C, we are all talking about long COVID. In hepatitis C, we have learned in the last 3 to 4 or 5 years that if you cure a patient from hepatitis C virus infection, persistent infection, with a new direct antivirals, that the immune system does not completely normalize. And this is what we, for example, published already 5 years ago, that there's still an altered cytokine and chemokine milieu in the blood even after cure of hepatitis C. And that is what we studied the blood. We published several papers where we looked at different immune cells, distinct immune cells, where we could see that the imprint of HCV persisted over time. And this even we could show if you treat an early acute hepatitis C. And this leads to the fact that also not all patients improve quality of life even after HCV cure, which we also showed in the German hepatitis C registry. So my message is patients after cure of hepatitis C should stay in surveillance. They need to undergo liver cancer screening, and we need to understand simply more what is happening in the long term when you take away HCV on the immune system. The very last message is obviously hepatitis C patients should drink coffee, and every liver patient should drink coffee. It has several beneficial effects on the liver. The most important point is that this beneficial effect is dose dependent. So the more the better. Thank you very much, Glenn.
Thanks, Heiner. Just a comment on the coffee. You know, since my time in medical school, it's either been good for you or bad for you, and it seems to be altered every 10 years. So now it's good for us. Steve, come on back on, please. Heiner, I'm going to ask, we've got a few questions. We're going to need short questions, short answers, please, so that we can stay on time. Heiner, I wanted to ask you, you commented on the liver enzyme increases and the transient nature, not being too concerned. So in the phase 3 study with factor VIII gene therapy, about 79% of the patients were on prednisone or steroid immunosuppression, some immunosuppression for 33 weeks out of the first year. And so those bumps in those transaminases, how do you think about them? And before you answer, the literature that I've looked at going back to the 50s would suggest that liver transaminase elevations, ALT elevations, signify death of hepatocytes, but I'm not totally clear that that's true. Can you comment on what these ALT elevations actually mean to what's going on inside of the liver?
So for me, it's very important as a pathologist when I get asked how to value this. Is only ALT increase? What's about ALT versus AST? And if AST, which is a mitochondria more, if AST higher than ALT, then something is going on. Then I'm concerned really. The simple ALT increase with not much going on AST, I'm quite relaxed. And there could be even, as you mentioned, not only that the cell is dying, that you lose really a cell, it could be even a leakage of ALT in the blood. That's one thing. The other point is, in particular, when you look at other liver enzymes, gamma GT, it could also be enzyme induction. So it's because we are talking about an enzyme and it's an enzyme activity. It's not necessarily that the cell is dying, but you have a higher activity, which could be induced, for example, by cytokines, that the enzyme is just more active.
Okay, thank you. Steve, we've gotten a couple of questions actually. One from Prasad Matthew on treating children with gene therapy. And it's a particularly timely question because you and I were involved in a discussion just a few days ago with gene editing and the concept of being able to use gene editing in rapidly dividing cells, such as in children, as a means for gene therapy in hemophilia of children. Would you like to comment on traditional or conventional gene therapy and what the prospects are for children, as well as what the future may hold?
Sure.
Briefly, please.
Yeah, so the AAV-mediated liver-directed gene transfer, I don't think any of us expected that this was going to be applicable to children because you're limited to transduce that cell a single time. The episomes that form are not going to be propagated if the cell is dividing. And so the risk would be in a rapidly growing, dividing liver that you would dilute out the gene transfer over time. So the current platform we're testing in adults, maybe it has some continued efficacy in adolescent patients, but true pediatric, well below age 6, even maybe below age 12, I think the efficacy is not going to be there. So does that mean gene transfer is completely off the table for pediatrics? I don't think so. I think there are now good strategies that can be hypothesized where you can use gene editing technology to either introduce the transgene into a targeted location that can be controlled for the most part, that would then be integrated into the DNA in that site and would allow for propagation into daughter cells for the growing liver. If we go that route, it's still going to have to be demonstrated to have safety and efficacy in the adult population first before it's offered to children. But I think the pathway is still there that gene therapy could be an option for children, but it's going to be sometime down the road.
Okay, thanks, Steve. We got a question about actually the COVID vaccines. And so just to reiterate, we've done a couple of webinars in the last few months on the COVID vaccine and hemophilia, encouraging everyone as they get access to take the vaccine and make sure that you are first in line to get it, because having a bleeding disorder and COVID is not a good combination. And we have published a few papers on that over the past year. and have included most recently a paper on the vaccine itself and what one needs to do to be safe in taking the vaccine if one has a bleeding disorder. What I might ask WFH staff to do would be put into the chat box, perhaps the URL for the webinar as well as for the paper, so that those of you who are interested could get access to that. But please, we do strongly encourage getting access to the vaccine and taking the vaccine.
And Glenn, if I may add, it's not only that, let's say, patients with your disorder are at risk. We're talking about the liver. And liver disease has also been a major risk factor for poor outcomes in SARS-CoV-2 infected patients. And therefore, it's quite clear that also from our perspective, these patients need definitely to undergo vaccination. It's no way, just do it. And even if you then develop just by chance, what I just mentioned, the slight transaminitis 2 weeks or 3 weeks later, don't worry, it will disappear.
Okay, thank you, Heiner. Coming back to the liver, the patients who have received the gene therapy, and as Steve mentioned, a number of them have a history of hepatitis C. They've been cured of their hepatitis C, and many of them have had hepatitis B transiently, and it's disappeared or been suppressed, whatever the case may be, for decades and decades. How should one, in light of some of what you've talked about in terms of the long HCV, how should we be thinking about that in the community where many people over age 35 or so have had one or both of these hepatitis infections? What should we be thinking about when we subject those individuals to another insult to their liver, namely gene therapy?
So again, and as Steve mentioned, obviously you should not include a patient with liver cirrhosis, which has not been done in the trials. It's quite clear. But then I think at this stage, the only option is really to follow the patients after gene therapy closely, because that's I also have to highlight. If a liver cancer is by chance happening, we have very good treatment. We have improved treatment. You can cure an early cancer therefore screening is everything. There are now 20,000 risk scores for HCC, which is a lot of research, but there is not the one score. As you don't understand the variability, why some patients have low and high activity, we don't have yet this score why which patient may develop HCC, yes or no. And therefore, the classical clinical factors should be excluded from clinical trials, then include them in the clinical trials, include them put them on treatment, and then we just have to follow them at a regular screening. That's all I can state at this stage.
Okay.
Hey, Glenn, just to follow up on that, and I think I saw a message in the chat as well. You know, as long as we're going to be continuing to rely on the liver for expression of these factors, the priority of maintaining liver health from childhood all the way up into adulthood, I mean, this should be preeminent. We absolutely need to be paying attention to diets, to growth and development in our younger patients, and counseling them about lifestyles that could be risking their liver, because if this is going to have any impact on the outcomes, and particularly the outcome after receiving gene transfer with this platform, let's make sure that we are educating the population well in advance and saying, look, keep those livers healthy so that you can get this kind of transformative therapy when you reach the appropriate age.
Thanks, Steve. So to summarize what both Heiner and Steve have said, we have developed the World Federation of Hemophilia Gene Therapy Registry to do exactly what's been suggested, to follow patients who have had gene therapy or will have had gene therapy for many, many years, perhaps lifelong, to track both efficacy as well as safety. And so that's going to be an important adjunct for monitoring liver health post-gene therapy as well. We had one last question about the, sorry, I lost it, but I think Yeah, the genotoxicity issue, Steve, you covered that. I think suffice to say that the genotoxicity issue that came up in the Unicure trial has been scientifically investigated with a level of detail and thoroughness to really exclude AAV as the cause of the hepatocellular carcinoma in this case. And so I think that issue has been put to rest. With that, I'm going to thank both Heiner and Steve for an interesting discussion and presentations over the course of the last 50 minutes. And we will move on to our next talk, which will be the highlights from the ISTH on von Willebrand disease. I introduced Nathan before, and so we'll leave it to Nathan to take on, and then we'll move into the next session or the next talk with Dawn Rodolini immediately to follow.
My name is Nathan Cannell, and I'm a hematologist at the Brigham and Women's Hospital and Harvard Medical School in Boston. And thank you for this invitation to talk about updates in von Willebrand disease from the International Society on Thrombosis and Hemostasis 2021 Virtual Congress. I have no significant disclosures related to today's presentation. And just as background, von Willebrand disease is the most common inherited bleeding disorder. And while it is inherited by men and women equally, it disproportionately affects women due to heavy menstrual bleeding and postpartum hemorrhage as well. The International Society on Thrombosis and Hemostasis holds an annual congress for presentation of basic translational and clinical science. And in addition to this, the ISTH has a standardization committee that is specifically focused on von Willebrand factor. And so I'm going to present key updates from the SSC meeting related to von Willebrand factor, as well as some key clinical science updates of abstracts and state-of-the-art talks that were delivered related to von Willebrand disease. So the SSC meeting for von Willebrand factor was kicked off with a discussion about the recently published von Willebrand disease guidelines. The title was about the guidelines, clarity and controversy, and this was presented by Professor Mike Macris from the UK. And throughout his talk, he was discussing the controversies around diagnostic thresholds, 30% versus 50%, treatment options, and the strength of the recommendations around treatments such as use of prophylaxis in patients, and the applicability to global populations. And of course, it's important to note that the guidelines took a high resource context with the understanding that there would need to be adaptation of these guidelines. And for anybody who is interested in reading more, the guidelines from the collaboration across the 4 organizations you see here are freely available via open access. So anywhere in the world with internet access can access them. The link is here, and in addition to links to the guidelines, this page also has resources for patients about the guidelines and links to specific resources across each of the collaborations. Subsequent presentations at the SSC actually went a little bit beyond von Willebrand disease and thinking about bleeding of unknown cause. And when you look at the prevalence in various registries, von Willebrand disease is very common, but as you can see here, bleeding of unknown cause is also very common across these registries. This is essentially looking at patients who've undergone evaluation for bleeding disorders and what could potentially be contributing. And the conclusions were that really we should start thinking about collagen vascular disorders, platelet function defects, problems with tissue factor pathway inhibitor. What is also interesting to think about this is that some patients that have von Willebrand disease may also have these other disorders and contribute to the bleeding phenotype. What is also great is that many of the treatments that we use for von Willebrand disease, such as use of desmopressin, with or without antifibrinolytics such as tranexamic acid, are often effective in patients with bleeding of unknown cause. And so it's important to think about patients may have more than one bleeding disorder that need to be managed and investigated. Another presentation during the SSC was about potential new treatment options for von Willebrand disease, focusing that the main primary therapies that are available at this point include use of von Willebrand factor concentrate, such as plasma-derived or recombinant von Willebrand factor to make levels rise. Levels can also be brought up by use of desmopressin, DDAVP, and the use of adjunctive therapies such as antifibrinolytics and hormonal therapy. And Professor Kasari discussed research about some other therapies, particularly genetic therapies that are being investigated currently in mouse models, such as siRNA, which unfortunately may only have mild effects on VWD and therefore not shift bleeding complications, but that gene editing techniques may be particularly helpful in patients who have double negative von Willebrand factor mutations. So they have two mutations in von Willebrand factor that significantly decrease levels. So if you could edit that, it may improve circulating von Willebrand factor levels. The remainder of the SSC presentations were primarily focused on some of the basic science and also evaluating available VWF concentrates. So there were several other presentations also looking at Adams TS13, which is the enzyme in the blood that cleaves von Willebrand factor. One thing that was particularly exciting to come out of the SSC meeting was this project update on the nomenclature for von Willebrand factor. And von Willebrand disease is broadly defined into two groups, quantitative or qualitative issues. Quantitative, you don't make enough of it, or you don't have it at all, type 1 and type 3 respectively. Whereas qualitative, the type 2s are loss of function. You have von Willebrand factor, but it doesn't do one of its jobs properly. In looking at the patients with type 1 VWD, there is a subset of them who have reduced survival, that the half-life of their von Willebrand factor is between 1 and 3 hours instead of the usual 8 and 12 hours. And since this represents a clearance defect, desmopressin may appear to work initially, but does not sustain its effects at the 4-hour mark. And so because this has treatment implications, there was a discussion that over the last 15 years, there are more and more data to support this. A survey was sent out to WWF SSC members about recognizing a new subtype. And so the ISTH Standardization Committee will be officially accepting type 1C as a VWD subtype. And more on this is to come with publications. But specifically with management, this is important that these patients will benefit from use of von Willebrand factor concentrate rather than desmopressin in order to manage bleeding. I'm going to move into the clinical abstracts now and then finish up with the state-of-the-art science talks. There were a few key clinical abstracts that I thought would be interesting for clinicians globally. And one of them was this oral communication evaluating the response to treatment for GI bleeding in patients with von Willebrand disease. And GI bleeding is common in VWD, especially with certain subtypes, depending on the types of multimers or in patients with type 3 VWD. At one center in Milan, where the presenter was from, there was a 16% lifetime incidence. And we know that von Willebrand factor has effects on vascular endothelial growth factor, and that this can lead to angiodysplasia, and that these lesions then bleed and cause bleeding symptoms. So it's a bit of a vicious cycle. When they looked at the 16% of patients with VWD who had GI bleeding, 19% of them had GI bleeding and needed long-term prophylaxis or rescue therapy. So using VWF concentrates or rescue therapy such as surgery, octreotide, lenalidomide, for instance. Another oral communication looked at an investigational agent, BT200, and this is a pegylated aptamer that binds to the A1 domain of von Willebrand factor, enhancing levels by decreasing clearance. And so preventing the clearance of von Willebrand factor to allow levels to rise. And this was specifically looked at in patients with type 2B von Willebrand disease, presented by Professor Qian Ai from Austria. And it was 3 milligrams on study days 1, 4, and 7, followed by 6 milligrams weekly through 28 days. And as you can see here, in this small cohort of patients, there was a significant rise in platelet count. And this suggested that the investigational agent was preventing the premature clearance of von Willebrand factor and platelets. Whether this will translate into improved clinical outcomes remains to be seen, but would need to be investigated in a prospective study. This is going to be something hopefully in the pipeline in the future as a new therapy in von Willebrand disease in the coming years. There were a lot of different posters that presented data on von Willebrand disease. I picked this one in particular because it looked at the clinical, economic, and quality of life burden associated with VWD, both through systematic and targeted literature reviews. And this was presented by Giancarlo Castaman on behalf of his colleagues. And they found 25 cost and resource use studies looking at nearly 80,000 patients with von Willebrand disease and found that there was huge variability in the reported costs associated with the disorder. There were higher costs for patients with VWD compared to patients without VWD. And in 17 of the studies that looked at health-related quality of life across about a little under 6,000 patients, all of the studies assessing treatment impact, except for one, reported improvement in single or multiple components of health-related quality of life. And this provides further evidence that patients with VWD who have access to treatment and are treated for their bleeding symptoms, it is not just the clinical outcome, but health-related quality of life, which is improved. In the last of the clinical abstracts, this was not an abstract with presentation of primary data per se, but a discussion to raise awareness about a pilot study that is going to be performed called the Vwd Woman Trial, looking at recombinant von Willebrand factor plus tranexamic acid versus recombinant VWF alone in the prevention of postpartum hemorrhage in women with VWD. And so the authors have received institutional and regulatory approval to proceed with this trial, and it's going to be recruiting soon. So hopefully in future years, we'll hear more data about this. But essentially, they're looking to take approximately 20 patients and randomize them to recombinant von Willebrand factor with and without tranexamic acid to see the effects on postpartum hemorrhage, to really provide primary data for its use in women with VWD at the time of delivery. The next several slides are going to talk about state-of-the-art discussions. All of these had illustrated commentaries in RPTH, research and practice in thrombosis and hemostasis. So I'm going to include them here so you can see the highlights. Professor Michelle Lavin from Ireland presented about the challenges of management of women with VWD, particularly around menstrual bleeding, identifying and testing. How do we objectively measure menstrual blood loss, and what are the best first-line therapies, such as use of estrogen with and without tranexamic acid, or thinking about therapies such as the levonorgestrel IUD. In pregnancy, understanding how pregnancy affects VWF levels and what are the optimal plasma levels. There are scant data out there as to what are optimal levels in patients who are going to receive neuraxial anesthesia or to how to prevent postpartum hemorrhage. And as you can see here, how do we actually define, prevent, and identify postpartum hemorrhage? And what about iron in the postpartum period and planning for future pregnancies? Professor Frank Liebig from the Netherlands presented about the impact of aging and inflammation on plasma VWF levels. We know that levels in the general population go up with physiologic aging, but von Willebrand factor patients with VWD will also have a similar rise, but it may not match what patients in the general population do. And so this age-related increase appears to be related to endothelial dysfunction and atherosclerosis, and discussing issues with release and clearance, as well as how this may affect patients was discussed. Professor James O'Donnell from Ireland talked about von Willebrand factor modulating adhesion of malaria-infected red cells to the endothelial cells, and particularly around Plasmodium falciparum. And so it just goes to show that von Willebrand factor has many other roles other than just in hemostasis, and that these platelet decorated VWF tethers can actually bind to the red cells that have malaria in them, and how this ends up affecting infection is still to be seen. And lastly, in the VWD state-of-the-art talk by Professor Jamie O'Sullivan, also from Ireland, looked at how does VWF affect regulation of cancer metastasis. And again, just another way in which von Willebrand factor has a role in the body. We know, as we mentioned earlier, that angiogenesis is affected, VEGF levels. Patients may have cancer-associated thrombosis related to the influence of von Willebrand factor. VWF will mediate inflammatory cytokines. And there's even this thought that platelets that are helping to promote metastasis may then tether on von Willebrand factor to promote migration and the ultimate metastasis of a tumor. So these are new therapy targets that can be considered in translational science. And with that, I will finish up and thank you for giving me this opportunity to
I'm just going to take this as my cue to go ahead and start. Hi, everyone. I'm Dawn Rodolini, and it's my pleasure to be here to recap the Global Summit on Women and Girls with Bleeding Disorders. Next slide, please. These are my disclosures. Next slide, please. So it was a great summit. It was July 8th through the 10th. We had 1,034 registrants from 118 countries. And then we had almost 500 people, 500 people attending this with us live from 82 countries. What I love about what WFH has done with these sessions, because of the different time zones across the world, that these are all recorded. And so people can come back and attend these at any time. You can see our top ranked sessions here. Hear Our Voices was a recurring theme throughout our 3 days together, and Cesar Garrido, WFH chair, opened our summit by calling out the disparities for women and girls with bleeding disorders. He also highlighted the need for more women in leadership positions, and that we must break down the stigma and increase awareness, diagnosis, care, and treatment. Cesar reminded us, and I just heard this in Dr. Cannell's talk as well, just that we really lack data about women and girls with bleeding disorders. So he really called out NMOs, HTCs, and importantly, WFH to focus globally on collecting the data on women and girls with bleeding disorders beyond hemophilia. We also learned from Baiba Zemeli that 1 out of 3 women in Europe with a bleeding disorder decided not to have children due to the impact of their bleeding disorder. So this is a major issue. Next slide, please. Just a couple of quotes. Of course, I took the best ones. This was a great conference. It was well planned and organized. I found the balance between materials for providers and consumers one of the most effective elements of the sessions I attended. I learned so much and was definitely inspired. And then I learned a lot, outreach and diagnosis. Michelle Lavin's presentation, Pamela Narayan and Christy Humphrey all provided perspectives, and the oral health topics was great. Next slide, please. So just to give you a sense for the summit format, but you can find these sessions on WFH's e-learning platform. But we had plenaries, we had education sessions, Ask the Experts sessions, hot topic exchanges, and toolkit sessions. The Women with Inherited Bleeding Disorders Committee took great effort to focus on making sure that our presenters were from all over the world. It was important, I mean, now more than ever before, that all of our perspectives are shared and that we can all work together for equity in our care. We had video testimonials for women and girls sharing their experiences. We also had these great video introductions to the day. Instead of looking at an agenda slide, they actually introduced the agenda for the day and talked about what they were excited about, which I really loved that format. Next slide, please. So these are going to be our highlights of our sessions. Next slide, please. So for our plenary sessions, multidisciplinary care for women and girls with bleeding disorders, what does it look like? Dr. Michelle Lavin discussed with us also outreach and diagnosis, and advocated for campaigns to drive awareness about heavy menstrual bleeding, such as Know Your Flow. She strongly suggested screening for all girls with heavy menstrual bleeding for a bleeding disorder. She reminded us that bleeding assessment tools are not sensitive to female bleeding symptoms, so this gets lost. And that while some women have normal factor levels, they can have abnormal bleeding scores. So we must pay attention to all the data and all the information we get. Dr. Jamila Sattar gave an excellent overview of the signs and symptoms session and what is not normal for a woman or a girl that could lead to diagnosis of a bleeding disorder. So we must listen to what they're saying about their symptoms. In the session, what are the health outcomes in women and girls and bleeding disorders? We heard from Dr. Robert Sidonio and Declan Noon about health outcomes and the importance of data in these outcomes. We learned that women share certain core outcomes with men, but that we must focus on identification of a bleeding disorder earlier for women and girls than when they get their first period. We're not prioritizing heavy menstrual bleeding as we should be, and that we must take greater focus on quality of life for women and girls with bleeding disorders that includes screening for anxiety and depression. Declan Noon reminded us that registries, even the very best ones, are not complete until they include at least 50% of women in the data. The registries also don't do a great job of recording what's labeled as minor bleeds, which includes nose, gum, and menstrual bleeding. So of course, all of these signs and symptoms tend to be ignored or not included. So when designing a solution for this population, we must focus on equity and not equality. Next session, please, or next slide, please. Educational sessions. Women and girls experiences. We're really lucky to have a physiotherapist perspective, psychosocial perspective, and OBGYN. On the topic of pain, Dr. Pamela Narayan told us that chronic anemia, which can be caused by heavy untreated bleeding, is an underlying cause of pain. However, the question about pain and then treating for anemia doesn't automatically come up in clinical visits. So it's something that clinicians must remember and be looking at. Christy Humphrey took us one step further when explaining that pain creates a fight or flight reaction in all aspects of life, that we can intervene psychosocially and interrupt the pain cycle. This really just underlined the importance in the comprehensive clinic setting to include PT and psychosocial presence when working with women and girls with bleeding disorders. Next slide, please. Our hot topic exchanges. So the hot topic exchanges were really just discussions. They were discussions held in a safe place that was honest and informative. You can see the topics here. I'm trying to get us back on time, so I'm not going to dive into all of the sessions, but I will give you an example of the oral health exchange. You might think, oh, oral health, of course, this is about dental care. In reality, we were talking about what the impact of bad breath and oral bleeding can have on the impact of intimate relationships. That's for both men and women. We talked about the fact that bleeding in the mouth for bleeding disorders is trivialized and ignored, but it has a major impact on everything from dental health, of course, but it has a barrier to intimate relationships. And so that we need to gather better data collection on oral health. Next slide, please. We had great amazing Ask the Experts sessions. And one of the suggestions that came out of one of these sessions was to build an international resource list of experts for rare bleeding disorders, and that providers could be able to use those, as well as NMOs and patients. Next slide, please. Our toolkit sessions were excellent. At the end of every day, we were able to cover some toolkits that really gave you practical tips and materials to take home back to your hemophilia treatment center or your NMO to be able to make a difference in your locality. So for example, the girls and pre-adolescents, how to talk about periods. This is before they get their period. So preparation and prevention. There were many visuals that were excellent, geared towards teaching younger girls, and also the importance of using your voice and creating a safe space to talk about this from a clinician's perspective. We learned that even if you aren't comfortable having that conversation with your provider, you have to overcome that and talk about it to get a good health outcome. There's huge universal stigmatization of periods and talking about this. And so that lack of comfort creates a barrier. And we both, patients and providers, have to work together to overcome that. And we did learn also that in the speaking each other's languages, when patients talk to doctors, we tend to want to make sure that the doctor is comfortable with what we're saying. And so it's interesting, and studies show that women are not very good at advocating for themselves. They're phenomenal at advocating for others. So it's something that we all need to work on. Next slide, please. So I just want to thank you very much. I promised to get us back on time. It looks like I did it. So I will take any questions at the end. Thank you so much.
Thanks, Dawn. You know, I think that was one of the best meeting summaries I've heard in a long time. Really, it covered, it offered your interpretation of the meeting with some conclusions. So thank you for that. One question for you. What are the next steps here? What to do to follow on from a conference like this that seemed to be very energizing and pointing us in a number of different constructive directions?
Yeah, thanks so much for that question, Glenn. And also for the kudos for the summary. I really think that WFH's next step is our initiative. Number one, we need to get a comprehensive initiative out there for women and girls with bleeding disorders. And this committee has been working on that. But attached to that has to be these things. You know, in the toolkit session, we utilize the VWD guidelines, the hemophilia guidelines for women and girls, that section on carriers, and also the European Principles of Care for Women and Girls that came out this year. And then, and so we looked at all of these tools that are already out there. The problem is they're just scattered. No one is looking for them in one place and how to use them. So I know the VWD guidelines group is working on how to actively use these in your home area. I think that's going to be a huge area. But I will say the next step, we've got to start collecting data, and women and girls have to start being included in trials. So we must start thinking about this population, because without data, we won't take a single step forward.
Okay, thank you, Dawn. There's a question, a medical question on VWD that I'd like to ask Cedric to answer. Will you diagnose VWD in a patient who has significant bleeding with von Willebrand factor activity by ristocetin cofactor of 53%? Repeated, it was 47, and then 56% again. and the VWF antigen is around 50 to 55%. Cedric, can you maybe expand a little bit on this question in terms of diagnosis?
Well, I think we need to be, thank you, Glenn, for this question. This is a very common problem. I think we need to be very cautious and not overdiagnose von Willebrand disease. These levels are, borderline, but, they are above 50% or very close to 50%. These people could have blood group O, which is, associated with lower levels of von Willebrand factor. So in my view, these patients should not be labeled as von Willebrand disease. I think that would be overdiagnosis. I think that to really have von Willebrand disease, you need levels much lower than that. I don't know exactly what the threshold should be, but certainly before 40 or ideally 30. So probably these people could be bleeding, could have bleeding problems, but maybe we have to explore the other aspects of coagulation. And also what has to be done is to repeat these assays, because we know that these levels can be changing a lot over time, but do not diagnose von Willebrand disease on the basis of this value. That would be my message.
Okay, thank you, Cedric. And based on a comment that Dawn made, I wonder if Steve, you might address a question regarding women in clinical trials. We have systematically excluded women in all of the clinical trials, or at least most of the clinical trials involving the extended half-life clotting factors as well as gene therapy. For as best I can tell, no particularly good reason. How do you suggest we advocate as a community for their inclusion?
In very rare cases, maybe there's some justification. I mean, I do believe there has been some concern at the gene transfer level with the systemic administration of AAV. You are going to transduce multiple tissues based on some of the tropism of these viral vectors. At least in a male, you can track the, seminal fluid, and you can evaluate for clearance through that mechanism, whether there's any impact on the cellular aspects of the semen, but you really can't do that at the ovary level in a woman. So I think I can appreciate exclusion, at least as we understand the current AAV gene transfer the way we're doing it currently. However, for the other therapeutics, whether we're talking about innovations in extended half-life, novel bispecific antibodies, some of these other, hemostatic rebalancing agents, I'm not convinced there's any justification for excluding women from these trials. I think if there's concerns about thrombosis, we can pay attention to risk factors, concomitant use of estrogen-based oral contraceptives, etc. But for a lot of women who have hemophilia, some of which even have severe hemophilia, why are they not included in these trials? And actually, it is changing, Glenn. I know in some of the current advanced therapeutics that we're using in clinical trials at University of Michigan, the sponsors have invited women to be part of the recruitment. And so I think we are seeing things change, and I think it's going to be welcome information for this population of people who really do need access to these novel therapeutics.
Okay, thank you, Steve. That's great to hear. Okay, so we're right on time. I'm going to turn the podium over to Cedric, who is going to introduce the speakers and manage our last session on prophylaxis with limited resources. Cedric, it's all yours.
Thank you. Thank you, Glenn. So we felt that it would be important to have a discussion again about prophylaxis, especially in countries with limited resources. And that will be the topic of the next session. So to address this very important topic, we'll have three speakers who have a great expertise in this field of prophylaxis. Dr. Vwd from Thailand, Salyu from Senegal, and Emma from Tunisia. So maybe the next slide. So, you know, prophylaxis is a very important issue, and that was very nicely and extensively covered in the latest guidelines of the WFH. You know, this very important document was published not so long ago. It's a very important document, and I invite all of you to read this document, and in particular this chapter on prophylaxis. Next slide. And this statement of the WFH is very important. Well, clearly, most patients or all patients should ideally be on prophylaxis, and the definition of prophylaxis has been revisited. As you can see on the right part of the slide, prophylaxis should be considered as the regular administration of a hemostatic agent or agents, considering that we have more than clotting factors nowadays, with the goal of preventing bleeding in people with hemophilia, while allowing them to lead active life and achieve quality of life comparable to non-hemophilic individuals. So I think this is a very important new definition of what prophylaxis means, and this is totally in line with recent innovations. Next. And as you know, this document does contain many recommendations, but I think the recommendations on this slide are very important because they should really drive our practice on every continent of this planet. Well, clearly, the WFH recommends regular, long-term prophy as the standard of care. And clearly, if prophy is not feasible, episodic therapy represents an alternative because it's essential to treat acute bleeds. But clearly, and you all know this, that on-demand treatment will not prevent the long-term joint damage. And clearly, considering that the access to replacement therapies is totally unequal on this planet, well, the WFH advocates for the use of prophy over episodic therapy in countries with healthcare constraints, but recognize that less intensive prophylaxis may be used as an alternative. Next slide. Before my colleagues do share their personal experience in their own parts of the world, I would like to emphasize what are, in my view, some of the critical requirements for successful prophylaxis, especially with low-dose prophy. Well, clearly, you need a long-term and uninterrupted availability of treatment, and that will be emphasized. Also, self-treatment and home treatment are critical. How do you want a prophylactic regimen, even low dose, without self and home treatment? What's very important too is adherence of the patients, good educations, understanding, motivations, and ambitions. Ambitions on the side of the patient, family of the patients, and healthcare professionals. And on top of that, you need, as you all know, a multidisciplinary team with hemophilia expertise, and that applies to all treatment modalities. So now, we will see what's the current experience in different parts of the world with low-dose prophy, and I will now give the floor to my Asian colleague to see what's the current situation in Thailand. Sorry, Taiwan. I give you the floor.
Thank you. So I cannot handle this one.
Yes, you have the slides.
I have the slide. Okay. But the video is not on.
No, it's okay.
Okay.
You can comment yourself.
Next slide, please. For Thailand, in order to achieve prophylaxis, we initiate with home treatment, which means it is the early episodic treatment, initiated in 1979. We use fresh frozen plasma, the frozen one, and then it changed to be lyophilized fresh plasma or lyophilized cryoprecipitate. This home treatment expanded to other patients and family. It initiated the exception of having blood product at home or the shared village refrigerator. Patients learn how to prepare blood product or factor concentrate and gradually accept venipuncture by parents and patients themselves, even for the medical personnel to accept the self-infusion. It takes time to make them familiar with the practice that the hemophilia patients are able to keep self-vinipuncture and self-infusion. Next slide, please. For the first study of the low-dose prophylaxis of Thai hemophilia started in 1994, we used the donated factor. Initially, we include 6 patients with hemophilia. The prophylaxis dose is low, 10 to 15 units per kg twice weekly for 1 year. The mean annual bleeding rate was reduced. They can extend their school. They're more healthy, and there's no need for hospitalization at all during the prophylaxis period of 1 year. Next, please. Next slide, please. Another study that we conduct in Thailand in 2016, when our National Blood Center, Thai Red Cross Society, are able to produce our own factor concentrate. 50 adult patients with hemophilia A are included. You can see that patients with zero bleed, 24 of them, and 26 of them have breakthrough bleeding, and the prevalence is not so high. In this meantime, no patient require hospitalization at all, but the patient with target choice exhibit more bleeding episode compared to those without target choice. Next, please. So this is an interview of patient, adult patient by the hemophilia patient group. We found that 49.5% of our patients receive 500 units of factor once weekly, and 28.9% receive 500 units twice a week. Thank you for your attention.
Thank you. And by one, let's now move to Senegal. Sadio, I give you the floor to explain what's the situation in Senegal for the moment.
Thank you, Cedric, for giving me the floor. Next slide, please. Next slide. So Senegal is a West African country with 16.5 million population. In our setting, we follow a cohort of 304 hemophilia patients. As you see, the median age of the patient are 13.3 years. So among the 134 patients who have less than 10 years age, 47 are actually on prophylaxis. Among these 47, we use low-dose prophylaxis for 16, and recently we, with the availability of emicizumab, we included 31 new patients on this program. So the indication of emicizumab prophylaxis are as followed. So as you see, 7 patients because they have inhibitors. We also have 16 patients with annual bleeding rate more than 8. And we also include 4 patients because they have antecedent of intracranial bleeds, and 4 also for GI bleeds. Next slide, please. So our actual protocol is that for the low-dose prophylaxis, we use an initial dose of 27 IU per kg per week for hemophilia A and 30 for hemophilia B. And as you can see, if there is no bleeding, we continue prophylaxis with the same dose. But if they have bleeding, we treat breakthrough bleeding with 20 IU kg per day. And if the patient has more than 2 bleeds in the 3 months, we make a therapeutic escalation with 2 injections per week. For emicizumab, we use the protocol with induction phase and the maintenance phase with 60 milligram per kg each month. Next slide, please. So as you can see, there is a result. Looking at the result for the low dose prophylaxis, we see that the benefit is real but very light in terms of ABR, HGH, and fish. If we compare patients with low dose prophylaxis versus on demand after 3 years follow-up. So there is a benefit, but this benefit is very, very light. However, if we compare the same patients on low-dose prophylaxis on their clinical profile before entering low-dose prophylaxis and after this, we see that there is a very sensitive signification improvement in terms of reduction of annual bleeding rate, of HGH, and improvement on fish. Furthermore, we also have no problem of compliance because 89.5% of the doses were used. Also, we see that 7 to 1% of our patients live all out of Dakar. So it is possible to manage this prophylaxis as they are not in the capital. And also the incidence of inhibitor is quite low. It is 20%. Next slide, please. So just my comment, I think that actually the current challenge and barrier for implementing prophylaxis is that the delay, of course, on prophylaxis initiation, because if you look on low-dose prophylaxis, the initiation age is 6.3 years. I think that there has something to do to improve this. So we also see that 55% of eligible patients in our cohort did not benefit from low-dose prophylaxis. And the main reasons was that they live in a residence far away from our health service, or we notice that there is not enough parents' motivation for regular follow-up, or also the fears of additional out-of-pocket healthcare costs for some patients. Next slide, please. So our expectation for the next year is that I think that one very, very important thing is that the improvement of social support. I think that we can't have a good hemophilia care if we don't have a health system strengthened. You have to strengthen the health system and to improve geographic and financial accessibility to care. And so the challenge is not only the availability of CFC, we need to improve this system. All the expectation is that actually we start the training for home treatment, and you have to continue this. Also, another point is that the use, I think, the more use of the emicizumab will encourage patients' acceptance of prophylaxis, because really it will be make more easy the adherence. And my last expectation is that, yes, in Senegal, we start now to have more experience on clinical trials. We are actually investigating new drugs on sickle cell disease, and I hope that in some time we can be able to be included for gene therapy clinical trials as investigator. Thank you very much.
Thank you, Saliou, for this great summary, also your enthusiasm. Let's now move to Tunisia with Emna. I give you a few minutes to share your local experience in Tunisia with low-dose prophy. You have a great expertise in low-dose prophy.
Thank you, Cedric. Did you hear me, and did I have a control?
Yes, well, I'm not sure you have the control, but just ask to move the slides, and that will be done.
Okay, so rather than sharing with you our results and experience over 14 years of low-dose prophylaxis in Tunisia, I will tell you the story of the introduction and the setup of a low-dose prophylaxis in Tunisia. Next slide, please. Next. Okay, I have no disclosure. So Tunisia is a low middle income country with limited economic resources. And in 2006, we were on 0.2 unit per capita, and we started to constitute a team dedicated to hemophilia. We started to abolish the use of cryoprecipitate and to generalize the use of the plasma-derived factor VIII for all people with hemophilia. And soon after, we introduced the concept of home treatment for some people with hemophilia. In 2007, we were on the consumption of 0.25 units per capita. And we started with low-dose prophylaxis in 2007, step by step. And you can see that the consumption, next slide please, the consumption of the clotting factor concentrate soon after the introduction of a low-dose prophylaxis increases step by step. So how started the story of low-dose prophylaxis in Tunisia? Next slide, please. So the first step was a case of a children, a 3-year-old one who was frequently in emergency with frequent bleeding, and he was diagnosed with hemophilia, severe hemophilia A, and finally we decided to start with him low-dose prophylaxis. Why? The question rises, and because the consumption of factor VIII for this child can be used for a low-dose prophylaxis, and that's what we did. Next, please. So we started with a 15 unit per kg 3 times a week, and we had an excellent evolution with no bleeding and less mother's anxiety. So the second step was to extend the experience to all children with frequent bleeding, with a regimen of twice or 3 injections per week according to facilities, and so venous access and the distance and the possibility to have a home treatment or not. And then all children going to school received also low-dose prophylaxis, as it was really efficient with improvement of quality of life for these children. In the third step, we had the opportunity of exchanging our experience in that, essentially during several meetings with the World Federation of Hemophilia, and we started to improve the concept of prophylaxis. So yes, it's low-dose prophylaxis, it was secondary dose prophylaxis, and then we started with primary low-dose prophylaxis. And then we started also to give prophylaxis with low dose for some adults. And next, please. So if how we were able to achieve all that? We have the involvement of patients and families. It's mandatory, but as Cedric said in the beginning, it's true that we need a multidisciplinary team, but the hematologist himself alone cannot achieve low-dose prophylaxis alone. So we will need the biologist for monitoring, but we will need the physio for the outcome assessment. We will need the physio for strengthening muscle, for working on proprioceptivity. We will need the nurse, essentially, for teaching people how to infuse. We will need the pharmacist to have regular supply of clotting factor concentrate. We will need other healthcare provider, and we'll need also the support of our NMO and the World Federation of Hemophilia. So if we summarize, we started, next one please. So we started in 2007 with episodic treatment with a consumption of 0.25 unit per capita. 7 years after, we had 50 children on low-dose prophylaxis. 1 year after, we pushed other hemophilia treatment centers in the country to use low-dose prophylaxis for children. We introduced also the prophylaxis for some adults, and also this consent for people with inhibitor. 1 year after, we introduced also the induction of immune tolerance induction. Now, our expectation, extended half-life products are registered, but we have a problem of tenders, so we hope that they will be available. Maybe we can use also now EZD full dose prophylaxis in order to improve. Emicizumab is ongoing to be registered for people with hemophilia. Hope it will be also available for people without inhibitors. And maybe we will have also the possibility to use new drugs. So at the end, we had some strength point. The major strength point was that NMO and healthcare providers work together, and the support of the World Federation of Hemophilia was mandatory for us, especially some experts, and especially Alok Srivastava and Jean-François Schweck. The opportunity now is that it will be easier for us to improve prophylaxis, maybe also to access to new treatment, and our challenges so are big. We still have some weakness, as there is some disparity between hemophilia treatment in the country, as for example in the north, all children now receive low-dose prophylaxis. It is around 50% in the center and in the south, and the threats in our country essentially is our political instability. So to conclude, healthcare provider, patient and parents, NMO and World Federation, and the support of government is mandatory to achieve and to set up prophylaxis in country like others. Thank you for your attention.
Thank you, Emna, and thank you for my colleagues to share so nicely how they could implement prophylaxis, what were the challenges, and what are the expectations and the challenges for the near future. So do we have questions at this stage? I do not see question on the chat.
I have a question, Cedric.
Yes.
Emna, I like the way you summarize the strengths, weaknesses, opportunities, and threats. And I wonder if I could ask Ampaiwan and Saliu what they see as the greatest hurdles toward continuing to develop prophylaxis regimens in their respective countries. Ampaiwan, Saliu?
Yes. And I think the prophylaxis is the key issue to solve the problem. But we have limited budget, so that's why the doses is rather low. Even we study prophylaxis in 1994 for the nationwide factor 8, factor 9, providing to all the registered hemophilia free of charge, starting in the year 2006. So in 2006, the government offered early treatment, and gradually it stepped up to be low-dose prophylaxis. So it is very helpful. You have to imagine how we persuade the patient, family to have the blood product at home and to perform cell venipuncture and plasma infusion at the beginning and change to be factor concentrate. So it takes time, but it's efficient and effective in decrease the bleeding. Right now, I do not have the cases of bleeding in the joint to teach medical students or medical personnel at all. They all receive home treatment, early treatment, and early prophylaxis. So the joint, the swelling of the joint, we have to learn and to teach them from the picture, not in the as the past. It's really helpful, but we are on the step to increase the doses.
Thank you.
For my side, I think that one of the biggest limits of expanding prophylaxis and to make it possible for all our patients is that we have a very, very, very good health system. You know, I wanted to emphasize it in my presentation. The problem is not only having the factor concentrate. If, for example, the patient had to go to the hospital and to pay with in pocket, it is a limitation, because as if the product is free, maybe sometimes they cannot have possibility to get transportation, to go to. So I think that strengthening the health system, making possible that all patients can have care in the hospital is one thing. Of course, we are actually developing homo treatment, but you know, all patients also cannot benefit from homo treatment. So my only expectation is really that plus the availability of products, that the health system be very, very good prepared to allow patients to be treated without any contract. I think that it can really improve access to prophylaxis for everybody.
Thank you, Sadio.
If I can add something, if you allow me, Cedric.
Yes, certainly.
Yes, I think that it's very important to emphasize on the collaboration between a healthcare provider, the NMO, and parents. They are good ambassadors to teach for home treatment, to teach for a regular follow-up, to exchange experience, and especially in the context of low-dose prophylaxis, mothers who had brothers or uncles who did not have the possibility to have home treatment and low-dose prophylaxis are the best ambassador to the new ones. And it's very important to have a collaboration between the different stakeholders.
Thank you for this comment. And as someone wrote on the chat, it's clear that home treatment is critical. If the patients cannot have access to home treatment, it makes prophylaxis very, very complicated, very difficult. You know, you do not expect from the patient to go to the center for every treatment, especially when they live far away. And I think home treatment is key here. And I know that in many countries it's still problematic. And someone also wrote in the chat that the patient should be trusted as well as their families. And I fully agree with this. Patients can be trusted. They know how this product should be used if they receive good education, good teaching about this, and they can manage their treatment themselves. And this is critical for the future. You agree with this, Emna?
Yes, totally. And it's also important, I think, because with children, it's not very easy in the beginning to needle them. So it's important also to try to identify a nurse who is living near a patient when he's very far away from the hemophilia treatment center in order to have easier way to start with prophylaxis. And it's important to communicate also. It's not easy. It needs a lot of efforts, but it's a big challenge. And now when I see what we achieved in these 14 years, I think if we were able to do that, other countries are also able to do it.
Yeah, and we receive again a question about how to develop the skill of self-infusion, well, of the patients and the family. I think that should be done by the hemophilia team, the multidisciplinary team with the nurses who have the experience, so that can be achieved. But again, that's why we need good hemophilia treatment centers with nurse, doctors, and other health professionals able to educate the patients. So Glenn, I think we are very close to the end. Maybe I should give you back the floor for the conclusion.
Okay, do you want to say anything about concluding this session first, Cedric?
Well, I think that was really nice, and I think that should stimulate all our colleagues who are struggling to implement prophylaxis, low-dose prophylaxis. I think it's possible. It's a major effort. There are many challenges, but that can be done. And when low-dose prophylaxis is implemented, I think this is the pathway to better treatment for the future. And I think these WFH guidelines are very important, and we should try to make everything possible to implement this, and low-dose prophylaxis is one of the steps forward. So thank you for the colleagues for preparing this contribution and sharing their local experience. I think it's really stimulating.
And Paiwan, do you have a final comment? I see your hand is up.
Yeah, I think to teach the home treatment, even you have the hemophilia team, but another important thing is to teach the patient. When they are admitted, we have to teach them to familiar with needle. The first step, I teach my patient to remove the needle, make them familiar. Otherwise, they will rely on healthcare personnel at all. I push the responsibility. I trust the patient. I trust the family. They are able to handle, but it takes almost a year for them to have perfect, complete self-unit puncture at home. It takes time, but it worth to teach them. They are more smarter than you expected. Thank you.
I agree. You're fully right.
All right, well said. Thank you. With that, we're at the end of our 2 hours. I would like to thank all of our speakers and panelists for a very engaging discussion covering everything from experimental gene therapy to low-dose prophylactic regimens. And so with that, thank you all. Thank you to the audience for also participating, and until the next time. Good day, everyone.